healthcare system is broken, but it doesn't have to be. This is Revenue Cycle Optimized by Infinix Healthcare. We discuss the latest challenges in the revenue cycle space and provide actionable tips on how to overcome them at your organization.
Welcome everyone, and thank you for joining us. I'm your host, Stuart Newsome, and today's session is titled Revenue Cycle from the CFO Seat, Signal versus Noise. Now, we're going to look at this revenue cycle stuff through a CFO lens, so to speak, a little different perspective. Not just as a set of operational metrics, but as a series of signals that can reveal things like financial risk, investment needs, and where finance and revenue cycle may not always be seeing the same picture. So I'm excited for this conversation because it gives us a chance to step back from the usual revenue cycle scorecard and ask a bigger question. What does this metrics actually mean to the financial strategy, to the health system? So joining me today is an expert in this. He's going to give us his experience as Jon Vitiello, who's our Senior VP and CFO at St. Luke's Health. Jon also serves as a member of the Infinix Advisory Board, and he brings a deep background in healthcare finance leadership, as well as health system operations. So Jon, rather than me trying to summarize your background completely, because I'm probably not going to do it justice, I'd love for you to tell everyone a little bit about yourself, your role, and the perspective that you're going to bring to today's conversation.
Sure. Well, first of all, thank you for having me. Pleasure to be here and share what I can. I would profess on the front end that I'm not a revenue cycle expert. I have never been in the bowels and running a revenue cycle, but I've had it reporting to me over the course of my career. So I think I know enough to be dangerous on the subject and certainly have an opinion about it. So in terms of background, I've been at this a while. I started with a full head of hair way back when. And my most probably recent or most relevant to this discussion is I had responsibility for a number of things, including revenue cycle, when I was at Mercy based in St. Louis. So at the time, about $8 billion flowing through the revenue cycle. There are a couple thousand employees working in that group across all of our hospital and medical group and other assorted operations. And then, as you mentioned in my introduction, thank you, is that I'm currently CFO for St. Luke's Health System, which is also based in St. Louis, a smaller independent and competing against Mercy, but I've got more direct line to RevCycle on a day-to-day basis again. So with that, I thought I will tell you what I know, and I'll stop when I don't know, and I look forward to the conversation today.
Sure, absolutely. So I'm always about filling in the gaps. But I think your insight is going to be very valuable for today's conversation, and your background brings the perspective that a lot of people really don't think about. But when we're preparing for today, one of the things that really stood out was the idea that revenue cycle and finance can sometimes be looking at the same business, but through very different perspectives and lenses. So today we're going to talk about how those two views connect, where they sometimes diverge, and how CFOs can better interpret the signals coming out of revenue cycle. With that, you ready to get going, Jon?
Yeah, let's do it.
All right. So Jon, from the CFO seat, what is revenue cycle actually measuring that finance cares about? What do you want to see at the end of the day? And where does those two views of the same business diverge?
Yeah, to your point, they're complementary functions within the same business, typically reporting both of them to the CFO, so to the same role, but they're looking at things differently. I'm going to oversimplify this, but in essence, I think about revenue cycle focused on more of the operational measures around the claims processing, the encounters that are happening, the operational throughput. The core question that leader is continually answering is like, how efficient and completely are we converting our charges ultimately into cash? Whereas the finance side of the world and accounting, they're living in the world of accruals and month to month, and they're thinking about margin. They're not thinking about the process, but their key question is different. It's like, what did we actually earn? What did it cost for us to earn that? And ultimately, like, where are we headed? Yes, they look backwards, but they're also looking forwards as to kind of what we have for. So as a result of that, you end up with, just like for some examples, you've got cash collections on the rev cycle side versus like net revenue recognition. So in essence, the accountant's worried about, did I collect all the dollars I said I was going to collect that I booked on the financials months ago? Did it actually come in? Really key. Days in AR on the rev cycle side versus on the accounting side, net revenue realization timing. So you may be telling me that the AR is at 42 days, but is that 42 days really a clean AR or is it full of junk? And so the realization rate on that's going to be actually lower than what I've currently got in the financials. Or that denial rate that you're telling me that's at 6-7%. Is that low and it's clean, or is that really kind of also loaded with high dollar inpatient surgical MA claims that are going to take 120 days to cycle through, and I'm going to overturn rate of like 30% versus like this. So those are, on the face of it, they can be understood by finance, but just the finances want to understand the economic impact ultimately. Both are legitimate ways of looking at things, but ultimately, like my job as CFO is to help kind of interpret between the two. And what I found, and as we're preparing for this, what I thought this might be valuable is I think that's not unique. I think that happens in a lot of organizations, that we might be sitting down the hall from each other, rev cycle and finance, but we don't necessarily know what each other's worlds are doing or how we look at the world.
Right, right, right. And it's, cash in the bank, and to your point, aging AR is a totally different animal. And again, to your point, there could be a lot of junk, and I guarantee you there is. There's a lot of information where revenue cycle is struggling to fight denials, and you're struggling to, well, we have margins to meet. We have, investments to meet, and especially if you're looking at growth. So, but you've also described what you call signals inside revenue cycle operations and how you can leverage those things that look operational on the surface, but they're often telling you something structural about the business. So if you could kind of walk us through what you mean and why CFOs need to learn to read them or interpret them or
Yeah, I
recognize them.
share. Yeah, and I share it. Hopefully, there's some other CFOs or people who want to be CFOs down the road in their career listening in. It's something I've realized probably later part of my career is that as I've gained an appreciation for rev cycle, it's a forward-looking, or can be a forward-looking portion of the business, in that that rev cycle individuals are interacting with our patients on a day-to-day basis. Obvious statement, right? Well, from a finance perspective, we're oftentimes looking backwards, like what happened over the course of the month or months, and we're not getting that retrospective kind of look. So, what I mean by that is, the rev cycle is the first to see a change in payer behavior, a downcoding of a procedure, for instance, hitting a remittance denial. Like that's not going to show up in finance until months later when there's a contractual adjustment happening, or
Right.
denial pattern starts to happen, kind of seen in a work list in rev cycle. They're not going to see that in finance until it becomes a reserve adjustment or a write-off, or they're seeing volume in mix shifts happening, as people are walking in the front door of that outpatient facility, or contract underpayment. So there's like early kind of in the process things happening that if you're paying attention to it and you're asking, you can get better information about what's happening to the business further on. It kind of like, it just raises the question, like, why doesn't that intelligence like naturally flow kind of upstream to the CFO? And I think, again, one man's opinion, but rev cycle is built for operational management, not necessarily strategic intelligence, unless you are proactive about that. And also, frankly, shame on us, we've divided the organization into silos, and we're not overstaffing all these silos. They have all this extra time. They're thinking proactively, what can I do to make life better for the CFO? Rather than think, how do I get my job done and get through this day and kind of get through the work in front of me? So that's an unfortunate part about it. And then last is that we're unfortunately conditional to backwards versus forwards. And so I think just being more intentional about that, it can turn this into a signal to help you understand what's happening in the business going forward.
Right, exactly. And as you're saying that, some of the things that come to mind for me, just from some of my past experiences, I'm always a big believer in being proactive and not reactive. And to your point, operationally, they're looking backwards because there's no other system like this out there in any other industry, right? So it has a lot of nuances, but we've seen to make it work for decades because it's been some of the same issues for decades. But being proactive is so key, because it's one thing for someone to look at an inventory of procedures that you do, how many procedures you did. Now you're looking at, the revenue that's associated with those procedures, and you can easily extrapolate, okay, well, we should be making this much money in the future. And you probably could if you consider the contractually allowable amounts and things of that nature. But then there's always those wrenches that get thrown in called denials. And for whatever reason, those denials occur because of the operational breakdowns sometimes in the revenue cycle. And so a lot of people just wash and repeat, to your point. It's like, I just got to get done what's what in front of me. And so they're working on some denials. The next thing you know, they're getting those denials reworked, which again costs 3 or 4 times more than you worked it the first time. So you're now spending more money reworking those denials instead of looking at, well, what caused this denial in the first place? And let's put in some things and procedures to make sure this doesn't happen again, which it will happen again because we all know payers change the rules. But yeah, you can mitigate those denials a little bit from a proactive approach. And that's just my spin on it. And I think that would help CFOs a lot as well in forecasting, so to speak.
I think so too. Great.
The next question is about Medicare Advantage, which has been one of the biggest defining shifts in hospital economics over, the last decade. How does Medicare Advantage growth show up in the revenue cycle before it shows up in financials? And what should CFOs be asking their revenue cycle leaders about Medicare Advantage specifically? We could do 3 or 4 sessions on Medicare Advantage, I'm sure. But
yeah,
yeah.
That's one of my favorite topics. Yeah. Yeah, and it kind of goes actually a little bit back to the last question around signals. So if you did go back 10 years ago, and I remember at the time of looking back at actually St. Luke's information here, like our Medicare Advantage rate was somewhere around 16% of our mix. It's now 28%. I also remember back then, we were contracting with Medicare Advantage plans for like 105, 107% of Medicare. Today we're contracting at 100 and getting paid less than 100. Doing our best to get back to that contracted rate at 100, and really because of the fundamental differences, like sort of because of the requirements of that Medicare Advantage or the managed part of the managed Medicare, it's being managed. So as a result of that, it's kicking off all of the various prioritization and other rules that are then requiring work on our behalf to support. So getting to your question, it's asking the revenue cycle leader what's different in the work. So as that Medicare patient turns to Medicare Advantage, there's now work, but there's more work involved. So how does that then change how you're staffing your teams as that grows? Is there technologies we ought to be investing in? Should we work with external partners because they can do it better and more effectively than we can? It gets to sort of that, kind of cost to collect kind of a question. But at the end of the day, this business is different. We're taking a business that was paying us, $1. It's now we're trying to fight to get back to $1, and there's a lot of now expense on us to provide. So in doing that, we got to be efficient. So I think really back to revenue cycle leader. And again, I think many organizations they're well past being introduced to this. They're in the midst of it, and it's here to stay. I got to imagine that Medicare is going to fully convert to this over time. Something dramatic, happens and it goes back the other way. But I'm not going to hope for that. I'm going to plan for MA being here to stay and acting more like a commercial payer than it is traditional Medicare. But to that end, got to resource it appropriately.
Right, exactly. Yeah, that's a big adjustment. And I think you're seeing, the future, you're forecasting, and I would agree with you. I think it is shifting, towards that. It has shifted, but it will likely be, the full gamut of how Medicare is going to proceed for sure. I don't see it going away either at all. Well, how should health systems think about cost to collect without falling into the trap of just trying to spend less? How do you know whether the RCM data that you're using, to make that decision is even reliable? Like you said before, oh yeah, I'm looking at this aged AR, but is it got a bunch of junk in it?
Tell you, it's a tough one for CFOs because myself included, CFOs tend to want to lead by example. They want to have very efficient, very effective, but very efficient, meaning as low cost and high value as possible functions that they're leading. Revenue cycle is no exception to that. But again, kind of lesson I've learned through my career is to think about it more as, because of the unique nature of what revenue cycle does, it's collecting revenue. It's a revenue generating function, in thinking about it more like an investment and a return on investment than a cost minimization problem. And so the question really isn't how do we spend less? It's really what's the marginal return on the next dollar that we do make in revenue cycle as an investment, and where does that return turn negative? Where does the return turn negative ultimately? So like when will we stop spending money there? I think for me, like it's, you got a number, that might number by 3.5% as a cost to collect, to throw a number out. It's hard, like overall, I say, okay, that's a good number. That's a benchmarkable number. Is it? I'll get back to that in a second. But that's for the whole function. For me, I think where we get more effective is segmenting that number out. And it's segmenting it out 2 ways. Well, one is like looking at the components of the cost to collect, the components of my revenue cycle operations, and what does each one cost? How much does it cost historically? And am I getting value out of each one of those elements? And looking at it as micro as possible or feasible. The other way to segment it is looking at it by payer class. And so, your cost to collect on your clean commercial claims might be 50 cents, or it might be a penny. to just use an example, and your MA, kind of back to the prior question, might be 25 cents. And they both might be appropriate. At the end of the day, that you're spending that 25 cents to go get those extra dollars, the extra millions of dollars that if had you not spent those dollars, you wouldn't be receiving. So it gets back to the just it's not there's a formula there, but there's just a mindset around how to break that down so that you can make sure that that sort of portfolio of expense that you have is really getting the dollars either individually in the case of kind of a portion of it or collectively. But you want to make sure that you're as effective as possible kind of across it, kind of how I think about it. On the data side to that, kind of how I interpret that question is like, you got to have obviously the data around what all those things cost or your best approximation of it, and then look at that over time. So even if you don't know that you've got it all broken down, at least you can look at it over a period of time and say, has my cost like wildly increased or decreased within your own organization? But then you can compare and benchmark to others. And the challenge there is that the same ingredients being put into that numerator and denominator by those comparable organizations or not. So that's really the kind of the key question to ask the benchmark organization is the normalization that's being done to ensure that the benchmark number, you understand what's in it and how that compares to your what's in it to say is that a reasonable comparison or not.
Mhm.
Tough one sometimes, but at the end of the day, you're making a management decision about how much you're willing to spend. That benchmark information is just consultant to you around that, but you got to make that call. And ultimately, you want to see that return on investment get better and better over time.
Right, right. Yeah. And there is such a focus on, oh, I got to spend less to get more. But sometimes, I've heard many wise people say, well, if you don't spend, you won't make more. And we can cut cost, certainly, but then at the expense of cutting costs, your revenues goes down. And that's where that data is so valuable because your revenue may be going down because you're having to hire more coders or maybe having to hire more denial management, personnel, or maybe you're having to hire more people who can handle patient access, on the front end. And that's not really that wasn't accounted for, or maybe you're cutting costs by letting some people go, which is what no one really wants to do, but then you're not collecting the revenue at the rate that you were. So yeah, there's a give and take, and I think the data is very valuable for that. So you're in the middle of a significant RCM transformation effort, right? So without getting into specifics, what convinced you that the investment case was real, and how did you structure accountability so the savings, actually showed up?
Well, this ties back to the previous discussion just a second ago. So when I walked in here, the organization had the opposite philosophy, which was let's get as bare bones as possible in rev cycle and save on the expense side. And in days and AR and revenue cycle really kind of went into a ditch. I'll leave it there. So we sort of immediately triaged the patient to try to stop the bleeding. Kind of walked in, brought some new leadership in. We tried to triage the patient and then kind of reorganize work. And then once we started to see that we made some immediate gains, and then we hired an external consultant to work with us on redesigning the entire function. And so kind of to your question, for me, the investment case was pretty easy in that, again, these are back to the prior conversation. If you're making the right investment in the right areas, you're certainly going to see a return on the dollars. So it gets back to how much conviction do I have and confidence that we're making those right investments. So for me, it's like just decomposing the elements of the transformation project and working with those individual leaders, challenging them on the actions they're going to take, challenging them on the timelines, challenging them on the resourcing that they needed. In some cases, adding resources for a period of time, challenging them around throwing people resources at it versus technology resources at it, and ultimately refining a plan that we're all kind of locking arms around, and then putting timing to it and putting numbers to it. Not numbers from a financial perspective, but like from a process perspective. So how are we going to see improvements in process, which then will turn into financial numbers, but along the way, and don't want to wait till the end. I want to say, how are we kind of measuring ourselves as we go, knowing things are going to improve and ramp up. It's not just going to be suddenly better overnight, but rather it's going to be something that's going to be slow and steady kind of throughout. So identifying those, agreeing to them upfront, and then continuing to monitor and discuss them. And frankly, when we have things that go off kilter, because you have a adult conversation and get back on track. is what we've done. And then ultimately, it's seeing those expense savings or those revenues, show up ultimately in the financial statements. That's the final proof pudding to all this. But you got to have the conviction on the front end to kind of go down the path and spend the time and the effort, because you're trying to do this change while at the same time you're trying to run operations. That is a tricky thing to do, and it has risk to it. So you got to have conviction on the front end that it's worth that risk.
Yeah, you're like you're flying the plane while it's being built. Right?
Exactly. Exactly.
So, and I like your analogy to the patient because, our slogan here at Infinix is heal revenue pain. And that's a nice analogy. And we take that to heart, because it's painful. It's painful, so many different levels. Well, the next question, I'm going to shift to patient access, more the front end of revenue cycle. It's become both a financial issue as well as an experience issue. Why is the front end so disproportionately important now? And what does good look like in that area?
Yeah, it's patient experience, for them and for us. I mean, we use our own health systems too, and I've recently been through ours, and we got a little work to do. But I think to answer your question, I think from my perspective, like real-time eligibility verification and benefit estimation at scheduling is one I really highlight as like what good looks like or as a best practice. Schedulation, sometimes it's an easy to say but hard to pull off concept. But that I think it's the highest impact move of shifting eligibility and financial clearance as far upstream into the process as possible, ideally at the point of scheduling. So when we verify coverage, confirm authorization requirements, and generate a reliable out-of-pocket estimate before the patient, ever arrives, it gives you three things, simultaneously. You reduce denials from eligibility and authorization failures. And I think I've seen numbers like 25 to 30% of all initial denials are tied to that. You sort of like can eliminate those. You're eliminating rework. You create the window to collect the patient responsibility portion up front, and because of that, then reduce the back end work. So you're getting the dollar sooner. You're doing that work more efficiently. You're reducing work on the back end. And I think ultimately the key is if you're able to do that, then making that a hard stop, up there in the scheduling workflow, so that when the schedulers start to become overwhelmed with a bit of volume that spikes, it doesn't become optional for them and then start to slip, but rather it's something that's hardwired in there. And you add schedule hours overtime to that volume as opposed to skipping steps and not doing the work. So I can't say that we're perfect kind of at any of that at this point, but we're striving to get better there.
Awesome. Awesome. So the last question I have for you is, St. Luke's has a large, outpatient footprint. Most encounters today never involve an inpatient bed in the experience that I've seen. But how should that change the way CFOs and revenue cycle leaders think about operations? And are most organizations still running an inpatient era playbook? Because there's two different sets of care, two different ways of billing, it's a totally different way of reporting in many instances.
Yeah, I agree. And we're right in the middle of that. I would challenge the CFOs to take a hard look. And I did recently. 97% of our patient kind of touch points of our volume is people not spending the night in the hospital. So we do about 12,000 admissions, a year. We got about 400,000 outpatient visits. I mean, to your point, those are fundamentally different. The rev cycle, we've always had outpatient, but using easy numbers, I think kind of just dial it back. We were 70% inpatient, 30% outpatient. At least where I am at St. Luke's, it's flipped. It's 70% outpatient, 30% inpatient. And so, but we still have to run both those parts of the revenue cycle, but we're running it off the legacy inpatient dominant portion of revenue cycle. So for instance, we're excellent at inpatient CDI, excellent at it, very, very, and we continue to refine that. We do zero outpatient CDI. We're changing that, particularly, for those more high intensive tests. There's other organizations ahead of us, but like we're having that realization of, boy, we got to get on that. And we can take some of our really good inpatient CDI people and they easily can learn and help us in the outpatient setting. And I think that's similarly just thinking about that set of processes, thinking about it differently, that you got this high volume, which also means that we got to get better at finding automation opportunities because that volume is going to probably continue to increase. And we probably have to change the reporting around it as well. Maybe break up our reporting, which we're talking about right now between the in and the outpatient. And I think as we do that, I think we're going to find that we're really underperforming on our outpatient portion of the business because we haven't been focused on it. So I think, to me, again, that's a thesis right now, but it suggests that there's opportunity for us to get even better with that, break apart of the reporting and focus. Maybe even we change some of the organizational responsibilities, the managerial responsibilities to accommodate that. But we got to just keep up with the changes in our business ultimately.
Yeah, absolutely. Couldn't agree more. And first thing that comes to mind when I hear you saying that with outpatient is E&M coding, such a big part of outpatient. And that alone can make or break you. Are you leaving money on the table because you're undercoding, or are you at risk of compliance because you're overcoding? And then you have payers like United, sorry, had to mention them, but they'll come in and say, oh, guess what? All your level 4s, we're going to jump to a level 2 or level 3 just because. Didn't even look at it. We're going to do that. So there's so there's different battles, in the outpatient world, I guess is what I was getting to there. But Jon, that's all the questions I have, but I'm now going to turn to the audience and see if there's any questions. We do have one question that's available here, and that is, if finance and revenue cycle feel like they are operating in silos, which you mentioned earlier, it's probably what sparked this question. What is the first practical step you would recommend?
Yeah, I did mention that at the front end. It's kind of obvious, isn't it? But like for CFO, I mean, it's obvious. Like, they report to me. I should probably bring them together. I should probably have finance, rev cycle, and maybe even contracting together at the table to break those silos down. I think it starts with reviewing the information together. We do that on a monthly basis as we're going through pre-close activities, as we're talking through revenue what we're going to be booking. It's got everybody around the table. And it's talking about what's happened and why that's showing up in the numbers for the month, but also did we talk about this last month, the month before? Now, what are we doing about it? What do we see coming for us in this coming period too? But the value in that is not just for me, but it's for the team. It's for seeing and talking about information they don't typically see on a daily basis, and seeing how their information impacts somebody else and how they're doing their job and how they're interpreting the information they're seeing. So you're better together as a team than you are in individual silos through that. So I think that, and then just jointly working together, because there's always things to improve upon. But rather than just running off and doing it on my own, is there a need for rev cycle and contracting to work together on something, rev cycle and finance work together on something, and for me as the leader of that, to hold them accountable, to say, we said we're going to go do that, now let's go do that together. And I think over time, I've seen that help to break down the silos, and I would recommend that for organizations going forward as a way. That's not probably the only way, but that's the way that comes to mind for me.
Yeah, that's sound advice, because I think, you're to your point, working as a team is so much better, not only for accountability, but also just good old-fashioned help, right? And there may be one department may be doing something where they're leveraging some new technology or different methods, and then you won't know about it until you're in a meeting among peers and say, hey, well, can I adopt that? It looks like something we could fit into our department as well. And so I think that collaboration is definitely key. Well, let's see any more questions. Jon, I want to thank you for joining us today. It was a great conversation. I learned a few things. Really appreciate the conversation that we've had here today.
Great. Well, thank you. Thank you for everybody who's tuned in to listen to us today. Hopefully they took away something from it. And again, thank you for having me, and maybe I'll have you back at some point in the future.
Oh, definitely will. Absolutely. More than one other time for sure. And yeah, and to echo you, thank everyone else for joining us today as well. You can also visit us at Infinx.com, where we have more articles, case studies, and insights on all things revenue cycle. So with that, we'll see everyone next time.
Thanks for joining us. Subscribe to get notified when our next episode is online. For more information for how we can help you increase reimbursements at your company, check out our website at Infinix.com. That's Infinx.com.